Good morning, everyone. My name is Alvin. I'm one of the chief residents. Welcome to Grand Rounds this morning. I have the honor of introducing our guest speaker this morning, Dr. Deepak Bhatt. He is the director of Mount Sinai Heart and the Dr. Valentin Fuster Professor of Cardiovascular Medicine at the Icahn School of Medicine at Mount Sinai in New York City. After graduating as valedictorian from Boston Latin School, Dr. Bhatt obtained his science degree as a National Merit Scholar at MIT. He received his MD from Cornell and MPH from Harvard. He is working on his executive MBA from Oxford. He trained in internal medicine at the University of Pennsylvania and in cardiology at Cleveland Clinic. He completed fellowships in interventional cardiology and cerebral and peripheral vascular intervention and served as chief interventional fellow at Cleveland Clinic, where he spent many years as an interventional cardiologist, associate professor of medicine, director of the interventional cardiology fellowship, associate director of the cardiovascular medicine fellowship, and associate director of the cardiovascular coordinating center. He then served as the chief of cardiology at the VA Boston Healthcare System and subsequently as executive director of interventional cardiovascular programs at Brigham and Women's Hospital. He was a senior investigator in the TIMI study group. Editor-in-chief of the Harvard Heart Letter, he became a full professor of medicine at Harvard Medical School in 2012. He was selected by Brigham and Women's Hospital as the 2014 Eugene Braunwald Scholar. He received the Research Mentor Award from Brigham and Women's Hospital Department of Medicine in 2016. The Eugene Braunwald Teaching Award for Excellence in the Teaching of Clinical Cardiology from Brigham and Women's Hospital in 2017. ACC's Distinguished Mentor Award in 2018, AHA's Distinguished Scientist Award in 2019, NLA's Honorary Lifetime Membership Award in 2021, and SCAI's Master Designation in 2022. Dr. Bhatt has authored or co-authored over 2,000 publications and has been listed by the Web of Science Group as a highly cited researcher from 2014 to 2022. He is the editor of Cardiovascular Intervention, a companion to Braunwald's Heart Disease and of Opie's Cardiovascular Drugs, a companion to Braunwald's Heart Disease. He is one of the co-editors of Braunwald's Heart Disease. He has served as senior associate editor for news and clinical trials for ACC.org and is the editor of the Journal of Invasive Cardiology. He was the PI for Charisma, Crescendo, Cogent, Reduce It, Soloist, Scored, and Intrigue, and co-PI of the 3 Champion trials, Stampede, Savor TIMI 53, Simplicity Hypertension 3, Themis PCI, and Reach Registry. In 2014, he was listed in the AHA-ASA Top Advances in Heart Disease and Stroke Research. In 2018, Reduce It was listed and also named the top cardiology trial by NEJM. In 2020 and again in 2021, Soloist and Scored were listed by the AHA. He was the inaugural chair of the AHA GWTG Quality Oversight Committee and served as trustee of the ACC, and currently serves on the board of directors of the AHA New York City chapter. Ladies and gentlemen, please join me in welcoming our esteemed speaker, Dr. Bhatt.
Great. Well, thank you very much. It's wonderful to be here with all of you, and it's really been a great several months at Mount Sinai. So I'm going to review some of the things that I think are new and interesting in the world of acute coronary syndrome, starting with the initial management, but a little bit about the secondary management of ACS. It's a broad topic, so I'm going to focus on some areas that I think are developing. Relevant disclosures for this talk include research funding from the bolded companies there, some of whose trials I'll be mentioning. And I will be talking about things that are off-label and investigational, both with respect to drugs and devices. So let me start first at the 30,000-foot view and make sure we're all using the same terminology. I'm going to be speaking really about secondary prevention here, that is the treatment of people with cardiovascular disease, specifically acute coronary syndromes. But in doing so, I don't want to diminish the importance of primary prevention, that is treating risk factors, or primordial prevention, that is encouraging healthy behaviors that prevent the development of the risk factors in the first place. As far as acute coronary syndromes, there has been some evolution in our understanding. Plaque rupture remains the most common cause of acute coronary syndromes. About 60% of patients with acute coronary syndromes have rupture of a lipid-laden inflammatory plaque that leads to superimposed, typically platelet-rich thrombus formation. So that is still the central paradigm of acute coronary syndromes, plaque rupture, accounting for the majority of ST segment elevation MI or STEMI and non-ST segment elevation MI or non-STEMI. But increasingly, it's recognized that plaque erosion is also a cause of acute coronary syndromes in about 25% or so of patients. And there, it's a matter of the endothelial surface getting denuded and formation, again, of thrombus, typically rich in platelets as well. And I can't really say platelets without acknowledging the fact that Dr. Collar's here in the front row. There are few people on the planet that have contributed as much to our understanding of platelets and thrombosis as he has, but really they do play a very central role in ACS. It's that combination of lipids and inflammation and thrombosis that, generally speaking, accounts for the bulk of the morbidity and mortality from cardiovascular diseases, including ACS. And about 5% of ACS, it turns out, are caused by calcified nodules. So these are rather tricky to deal with sometimes. In the cath lab, for example, they can lead to underexpansion of stents. There are ways of debulking plaque that can be useful. But at any rate, this sort of protruding eccentric nodular calcification can also generate an acute coronary syndrome in the wrong circumstances. So those are some what I'll say are common causes of ACS. There are less common causes as well worth knowing. These show up in life every now and then. They show up on board exams all the time. But coronary spasm is one of those causes of ACS, and about 1 to 5%, it depends on the exact study or population you're looking at. As I'll get into a bit later, oftentimes that spasm is occurring at the site of underlying atherosclerosis, whether you see it or not on an angiogram, it's often there hiding. Spontaneous dissection is the cause of ACS, and another maybe 1 to 4% or so of patients. I'll get a bit more into that. We've learned a lot more about coronary dissection in recent years. And then finally, embolism can occur, for example, in someone with atrial fibrillation or left ventricular thrombus or endocarditis. Again, a rare cause, maybe 1 to 3% of acute coronary syndromes. So just to make sure that people are at least a little bit awake here early in the morning, here are some angiograms. So this is a coronary angiogram, an invasive coronary angiogram in the PA cranial projection. The views don't really matter, but when they're cath lab, we take multiple views in 2D and in our brain are essentially reconstructing a three-dimensional image. So this is diastole and this is systole. This is the left anterior descending artery. So this is what it looks like in diastole, maybe mild, moderate amount of plaque in the mid-LAD. In diastole and in systole, there's almost obliteration of the coronary lumen. Any of the residents know what this is? No takers, not enough coffee yet? Okay. Well, this is myocardial bridging. So as you know, most coronary flow is occurring in diastole, but systolic compression is what is known as myocardial bridging. That's very rarely the cause of acute coronary syndromes or anything like that. But in this particular patient, it was. He did come in a bit tachycardic. That might have had something to do with it. But at any rate, we did go a step further beyond just the angiography, looking at the flow down that artery over time. And without getting into the technical details too much, this is a fractional flow reserve. We're looking at the pressure drop across a potential stenosis. And 0.76 means about if you consider 1 normal, there's about 75% or 76% of normal flow. So that's an abnormal amount of flow that's there. And in the cath lab, we can use things like adenosine provocation, or in the case of bridging, dobutamine provocation to enhance myocardial contractility. But at any rate, this was true and related here as the cause was ACS, but we treated him with high doses of beta blockers and other medical therapy, and he did well. All right, here's another example of a patient. This is a guy, if I remember right, in his early 30s that came in with sudden cardiac death, but fortunately was resuscitated. And this is what was happening on telemetry in the hospital, non-sustained ventricular tachycardia. a pretty ugly looking morphology. That'd make anyone nervous if that's happening in the middle of the night or the middle of the day. We took him to the cath lab, again, invasive coronary angiography, and this is what it showed, a 99% mid-LAD stenosis. But then we did give him some intracoronary nitroglycerin, and there's still plaque there, a moderate degree of plaque in the mid-LAD, but not quite so bad. And here's his right coronary artery, where again, in the mid-right coronary artery, there's a moderate degree of plaque, not obstructive, what we would call non-obstructive coronary artery disease. So does anyone know the diagnosis here of what this patient had? Note takers, a shy bunch. That's unusual among residents these days. Okay, this is coronary artery spasm. So again, something that isn't a common cause of acute coronary syndromes, but in this gentleman, it caused sudden cardiac death. And here he was treated with high doses of calcium channel blockers and nitrates, and well, actually, he didn't do well. He came back again because he was not adherent to his meds. But once he came back again with sudden cardiac death, after that, he actually was adherent to his meds. So you don't see as much of this anymore just because of widespread empiric use of calcium channel blockers and nitrates in people with chest pain of any sort, but it's out there. And this is his cardiac MRI just for fun, showing the left anterior descending artery, moderate degree of plaque there, and the mid-right coronary artery, also moderate degree of plaque. And that's the point I was making before. Unlike what we used to think maybe 20 or 30 years ago, most times spasm that's occurring, even in a young person like him, is in the setting of there being some degree of underlying plaque. You don't always see it on an angiogram, but sometimes it's just in the vessel wall and not in the lumen, which is what we're looking at in an invasive coronary angiogram. At any rate, those are just some interesting cases of, I wouldn't quite call them zebras because they're more frequent than zebras, but they're maybe not horses. And it's important to know about those because they really do show up in real life. In terms of the overall algorithm for managing ACS, it's summarized here. And in general, we bin ACS into two broad categories, ST segment elevation or no ST segment elevation. The ECG 12 lead remains the standard of care for doing that. And then in either case, the initial treatment is with antiplatelet and anticoagulant therapy. That's really the bedrock of what's done. And then in those that have ST segment elevation, if a cardiac catheterization lab is available within 2 hours, which is true everywhere in the greater New York City area, but not true everywhere in the country or world. But if that is true, then the patient really should go on to prompt coronary angiography. And then if there is a blockage or severe stenosis, then they should go ahead with percutaneous coronary intervention almost all the time when it's ST segment elevation MI. If for some reason there isn't a catheterization lab available because it's a rural region or it's a blizzard or it's a COVID pandemic or any number of reasons that come up in life, then prompt treatment with lytics and transfer to a center that can do percutaneous coronary intervention is indicated. Now, for non-ST segment elevation ACS, it's pretty much a similar algorithm, though the timing is not quite as urgent in general. And the algorithm beyond the ECG, if there is an ST segment elevation present, is a matter of looking at the high sensitivity troponin. In general, within 1 to 3 hours would be the time to look. It depends which data or guideline you're quoting, but somewhere in that time frame, basically early on. And if it's positive in the right clinical setting, that's a non-ST segment elevation MI, and then it's back to the cath lab and treatment with PCI or coronary artery bypass surgery or medical therapy. There it's not always PCI, it's about 60 to 70% of the patients that get stented, another 10, 15, maybe up to 20% that get bypass surgery, with the remainder getting medical therapy. And if the troponin isn't positive, well, that's unstable angina. Even there, if there are high-risk features present like heart failure, ECG changes, ongoing chest discomfort, or hemodynamic instability, those patients should all go to the cath lab. But if those things aren't present, then an initially conservative approach with medical therapy and risk factor control is appropriate. And then there should be some non-invasive testing. Historically, that has been the stress test. That is, get on a treadmill, exercise, watch what happens to the ECG and blood pressure, maybe do an echo or nuclear scan along with it. Although more recently, many centers have moved in the setting towards using non-invasive computed tomography angiography, or CT angio, to non-invasively look at the coronary artery anatomy. And in either case, however the testing is done, if that's abnormal, that means back to the cath lab. But if that's normal, then it'd be continued medical therapy. So that's the overall algorithm. Now, there are some patients that end up in the cath lab that have had a myocardial infarction with non-obstructive coronary artery disease diagnosed. That's called MINOCA these days. And I'll get into that a little bit more in a moment. Just to finish off, though, the ST elevation MI algorithm, as I mentioned, if someone has a STEMI, really they should be brought to the closest hospital that's PCI capable and undergo primary PCI. But if the hospital that's close by doesn't have that capability, then just bring them to whatever the closest hospital is. Ideally, that hospital would be part of a STEMI network so that they can promptly refer to some other hospital that can do PCI. But if you do end up in a situation where that's not possible, as I mentioned, full dose fibrinolytic therapy remains the standard of care. Though I would say if people are 75 years of age or older, there's enough data now to support a half dose lytic. And in either case, regardless of the dose of lytic, they should be transferred to a PCI capable hospital and most often will still undergo PCI. Let me review a little bit now about the guidelines that I think are most relevant. There are many guidelines in cardiology, and it would take a lot of time to review all of them. But let me focus on what I think are the most interesting guidelines pertinent to this topic, which are the chest pain guidelines. These guidelines were written for chest pain, not necessarily acute coronary syndrome, but that's okay because when you're seeing a patient, you don't necessarily know that they're having an acute coronary syndrome. Hopefully, you'll eventually sort that out, but at that initial meeting, you don't actually know. You're just meeting someone with an presumed ischemic chest discomfort syndrome. And these guidelines are color-coded. They've got a nice acronym here, chest pains, that hopefully reminds you of all the important things to do, such as the C, meaning chest pain means more than pain in the chest. That's to remember that there are other symptoms that can occur, things like nausea, shortness of breath, diaphoresis. Although the most common symptom is, in fact, chest discomfort of some sort. But those other symptoms are sometimes the ones that the patient mentions or are elicited more prominently. So just need to realize that even though these are called chest pain guidelines, more than chest pain is at work potentially. The H is for high sensitivity troponins. The E is for making sure patients seek early care. The S is for shared decision making, which is very popular these days in many parts of medicine, now ACS as well. Though, of course, you have to use some common sense there. If someone's having a STEMI, you don't want to just sit and debate the merits of quick care in the cath lab. But for low-risk ACS, for example, there, should you get a stress test, CT angio, empirically treat, there's certainly room for debate, and their shared decision-making can be very useful. Testing, this is actually a reminder to not test in low-risk patients. So patients that are very low risk with chest pain, troponin negative, ECGs negative, symptoms are stable, have been there for a while. That's not an ACS, and that patient may not need much in the way of further testing. P is to remind us to use clinical decision pathways. A is for accompanying symptoms, specifically reminding us that women may be more likely to present with accompanying symptoms than men. But again, they are still most likely to have, among those symptoms, chest discomfort. Most ACS do have chest discomfort as part of the symptoms, but which ones the patients may highlight can vary, and that does seem to vary by sex. I is for identifying patients most likely to benefit from further testing, and as a reminder that non-cardiac is in, atypical is out. I'm not a believer necessarily in being the word police, but there is a movement in cardiology to get out the word atypical as a descriptor of chest pain, because in general, it's believed that's code for saying that's bogus chest pain, get her out of here. So it was really meant to try to move us away from thinking like that and realize, look, if the patient's coming with some symptoms, figure out what it is, and if it's non-cardiac, don't dismiss it, but identify the fact that further cardiac workup isn't necessary. Other types of workup are necessary. And S is for structured risk assessment and the fact that that should be used as opposed to doctors just eyeballing it or winging it. But to summarize some of the highlights of these guidelines, conceptually, these were the first US or international guidelines for evaluating chest pain. The preceding guidelines all focused on disease state, like heart attack, or on testing, like stress testing, or on procedures, like stenting or PCI. So these guidelines really were meant to look at things from the patient perspective and also to an extent from the doctor's perspective on first evaluation. The recommendations are for both acute and stable chest pain. It incorporates the use of contemporary imaging techniques like CT angio, whose time has finally come. There's an emphasis on unique aspects of evaluating women with chest pain, including assessment of microvascular disease and non-obstructive coronary artery disease. As I mentioned, there's this movement away from atypical chest pain as a descriptor because it's meant sometimes as a way of dismissing symptoms, which we don't want to do. And there's also an emphasis on intensification of preventive therapy. So it's not just a focus on what you do right then and there for that ACS patient, but also how to keep them from coming back with a recurrent ACS. All right, well, that's all I'm going to say about ACS broadly. I'm going to move on now to talk a little bit about premature myocardial infarction. That's myocardial infarction in the young. And you know, the definition of young, of course, varies as one gets older. And the studies that I'm going to cite are a bit all over the place. But in general, I'd say these days, an MI in someone less than 50 is premature. And about 1 in 8 patients with a premature MI have this entity that I referred to, myocardial infarction with non-obstructive coronary arteries, or MINOCA. That can be associated with a bunch of things, but you know, you always want to think about recreational drugs, methamphetamines, especially cocaine. Another cause to consider in the young is spontaneous coronary artery dissection, or SCAD. This is an important cause of premature MI, in particular in women, especially in the peripartum period. Peripartum can mean before, during, or after. The most powerful secondary preventive measure in people with young MI is smoking cessation. Very high prevalence of tobacco and other drugs in folks that are coming in with MI at a young age. Here's a schematic of the numbers and how to look at it. So about 80 to 90% of people with premature MI, in fact, have obstructive coronary artery disease, the same thing that older people have. So, you know, don't be overly distracted by age. Common things are common in everybody. But in the young, about 10 to 20% have this MINOCA that I mentioned, and about 5% or so have SCAD. And for obstructive coronary artery disease, well, it's basically treated the same way as it is in older people. You focus on risk factors, though smoking is very prevalent in these people, as I mentioned. High LDL is very prevalent. Familial hypercholesterolemia is more prevalent. Elevated Lp(a) is more prevalent. That seems to be a potent and independent cardiovascular risk factor that doesn't have specific therapies now, though it does appear you get more bang for your buck from LDL lowering when the Lp(a) is also high. So that is something that is kind of actionable. If you see a high Lp(a), you want to be very aggressive with LDL lowering and consider things like the injectable PCSK9 inhibitors. And I already mentioned substance abuse is something to consider there. And the treatments are basically often a trip to the cath lab with a stent or PCI, dual antiplatelet therapy, statins, and the typical sort of things for ACS, like ACE inhibitors, beta blockers, that sort of thing. Now, for MINOCA, it sort of depends what the cause is. That's a number of underlying causes. And there are ways to really nail down the diagnosis. I'm not saying that these are always indicated, always useful, always cost-effective, but in the cath lab, there are things like OCT, or optical coherence tomography, not just taking a picture with contrast dye, but actually going inside the artery, taking images with sort of fancy equipment. Another way to do things non-invasively is to do cardiac magnetic resonance, MRI, to look at the myocardium and also potentially to look at the coronary arteries. So these are ways, invasively or non-invasively, of trying to figure out what caused that MI with non-obstructive coronary arteries. But in MINOCA, the underlying causes are more often things like plaque rupture, so it's traditional, but also plaque erosion that I mentioned before, and smoking is a potent promoter of both things, including plaque erosion. Other sorts of risk factors to consider in this situation, MINOCA, might just be thrombogenic disorders, hypercoagulable states, that sort of thing. And here the management really we don't know what to do unless we figure out what the underlying cause is. So there might be some utility, even though not totally evidence-based, in additional testing to figure out what the underlying cause was. For example, provocative testing might be useful to see if coronary spasm is the cause. If that's the cause, the treatment would include things that prevent spasm, like calcium channel blockers and nitrates. If it's plaque rupture, then it'd probably be the typical sort of treatments. But if it's non-obstructive coronary artery disease, well, there the data don't actually support putting in stents, but do support other medical therapy, as for ACS patients. And for SCAD, they're important to know that the demographic is typically younger women, and by that I mean women less than 50. And they're, depending on the series, about 10 to 30% of ACS in that demographic might in fact be due to SCAD. So even though overall it's pretty uncommon, in that particular group, it's not so uncommon. And as I mentioned, pregnancy is definitely a risk factor for that. Fibromuscular dysplasia, another thing to think about. We happen to have a lot of expertise here in vascular medicine in treating fibromuscular dysplasia. And there the treatment is, well, we don't really know the best treatment for that. There's an international effort going on to try to figure that out. But right now we think it's probably aspirin and beta blockers and ACE inhibitors and statins, like with everybody else. But maybe that's not entirely true. The role of dual antiplatelet therapy is a bit more controversial. Some people say, well, just treat it like an ACS. Other people say, maybe it promotes intraplaque hemorrhage. Who knows where the truth is, but hopefully there'll be trials to actually address this in the future. So just some characteristics of unstable coronary plaques. This is more for fun. These are OCT images, so using advanced intravascular imaging to get a picture of the inside of a coronary artery. Here you can see plaque rupture. And if you don't look at these things, you may not, but right here is a discontinuity in the plaque. If you can see where my cursor is pointing, and an underlying plaque underneath. So that's plain old plaque rupture here. This, on the other hand, is plaque erosion. So, here's the catheter, that's the circle in the middle, the OCT catheter. Here's the lumen of the vessel, and here's the plaque with some fronds coming out of it. So this is plaque erosion that we see here. This is a calcified nodule. Again, here's the OCT catheter. Here's the lumen, which isn't a nice circle because it's being impinged upon by this calcified nodule. And the calcium is shadowing the light. That's why you might think calcium should be a whitish nodule, but that's why it isn't in this type of imaging here. So some causes of ACS in general, also in the young, what they might look like if one did intravascular imaging. So what is young is a bit arbitrary, as I said. The most common definition is less than or equal to 50, but different studies use different ages. Some use sex-specific cutoffs, so that's become less popular these days. And Minoka tends to be much more common in young folks presenting with MI. So just a few factoids then here for you. Young individuals tend to have less extensive disease compared with older individuals. Approximately 1 in 8 patients that is young with MI has non-obstructive, meaning less than 50% stenosis plaques, what I refer to as Minoka. The lower the age, the higher the prevalence of Minoka. Approximately 1/2 of patients have single vessel disease. The LAD is the most frequently involved artery, though maybe that's not true. Maybe those are the ones that make it to medical attention. Maybe there are other people that aren't making it to medical attention, but at any rate, the ones that show up, the LAD is the most frequently involved. Left main is uncommon in this setting. Young women are more likely to have Minoka and less likely to have multivessel disease compared with men. And again, SCAD accounts for up to 35% of women with acute MI that are less than 50 years of age, and particularly peripartum. Some characteristics specifically of men with respect to premature acute myocardial infarction. Erosion is more common in this situation in women than in men. The non-culprit lesions tend to be fewer, shorter, more stable. Non-obstructive coronary artery disease is more common in women, as I mentioned, a higher prevalence of SCAD, higher percentage of single vessel disease. This may not be actionable, but a higher prevalence of congenital coronary anomalies as well have been described in the literature. Less likely to receive evidence-based medication, less likely to undergo angiography, and more likely to be treated conservatively without revascularization. And here just is just some more in the way of imaging, just to keep you all awake and interested. This is looking at a case of plaque rupture. if you look at the angiogram, that's what we would just call maybe mild coronary artery disease. Maybe some people call it moderate. A couple of decades ago, we would have just said normal coronary arteries, get out of here. But it turns out that even when it looks like that on an angiogram of the right coronary artery here, on OCT imaging, we can see a large lipid-rich atheromatous plaque with a large necrotic core. So that's what is represented where my cursor is pointing. So this really illustrates the fact that an angiogram might look okay. You might say, oh, well, this doesn't look so bad. Why are they here? But there might, in fact, be a good reason for the chest discomfort and, at a minimum, a good reason for aggressive secondary prevention, even if this ended up being true, and unrelated. Here as well, further downstream in that same plaque, we see more evidence of ruptured plaque with an empty cavity. So that's where my arrows point. So again, this is the OCT catheter in the middle, that's the circle. This here is the circular-ish lumen of the coronary artery, but this is a ruptured plaque with an empty cavity. That means it's ugly contents of plaque and lipid and inflammation have been extruded. So this person's lucky that they didn't have thrombus form here and have an occlusive or semi-occlusive lumen that would have resulted in a large MI potentially. So shows the value of preventive therapies. Perhaps this person was on antithrombotic therapy and that kept that plaque rupture from developing into a much more serious event. So that's plaque rupture. This is plaque erosion. So here is another coronary angiogram of the right coronary artery. Right here, this is very minimal plaque. Again, in years past, we would have just said normal coronaries, but it's a little hazy. You can perhaps see the nice, dense iodinated contrast here, but here it's a little hazy. Here it's actually a little hazy. Here it's really hazy. And what we see at this arrow is a calcified nodule. So again, impinging on the lumen. Actually, here it makes it look like it's really impinging on it, much more so than this two-dimensional angiogram is able to show us. Maybe in another view, in another angiographic view, that this area here would have looked worse. But in this one view, it doesn't look so bad on the angiogram. But here, pretty narrowed lumen from that calcified nodule. And then further downstream in the artery, where it looks really hazy, this is what is seen on an optical coherence tomography. A red thrombus and underlying atheromatous plaque without apparent rupture. So very insightful sometimes doing OCT, not part of routine clinical practice, potential risks of dissecting an artery, added expense, but still perhaps in the future, this type of advanced imaging will give us a better sense of what is really going on in a lot of patients who in the past we would have just said, oh, you know, this doesn't look so bad, get out of here. And here is another example. This is, I think, a 30-ish or 40-year-old woman with a positive troponin coming in with a suspected ACS, quote unquote, normal coronary arteries on an invasive angiogram. Looks like must be a false positive. Who knows why the troponin's positive? No, actually, it really was an ACS. So this is a non-invasive CT angio. There's non-obstructive plaque here. So the angiogram wasn't wrong in terms of there not being a severe stenosis that needed a stent or bypass surgery, but the interpretation of the angiogram in terms of normal coronaries was in fact wrong. There is plaque predominantly in the artery wall here, but you can look on these various images of MRI. In fact, what it is an infarction in the septum. And here are different views, different MRI weighting, but you can see where the arrow points, hopefully, an abnormality. So here, for example, this should all be black, but you see a little white protruding in there. That is an infarct in the septum. And if you look very carefully at this non-invasive CT angio, things that actually weren't noted and probably couldn't have been seen in an invasive coronary angio due to issues of resolution, there's this moderate LAD plaque, but in the septal perforator, right here where my cursor is an embolus, probably from that plaque. So in fact, there was an occluded artery. Now this septal perforator, it's less than 1 millimeter. You couldn't do a stent in it, you couldn't bypass it, nothing you do other than medical therapy. So maybe this series of expensive testing doesn't really change what we're going to do with this patient, treat her as though she had an ACS since she came in with chest pain and a positive troponin. But still, it does provide some insight into the fact that, yeah, actually she did have a septal infarction, even though it didn't show up on an echocardiogram or an ECG, the troponin didn't lie. Here's another example. This is a 36-year-old woman who presented with chest pain 2 months after delivery of a baby. And what you see here, oh, unfortunately, I gave you the answer right here at the top. Well, pretend that isn't up there. But you can see an LAD coming down here, and then it's really narrowed, really tight, a 95% stenosis. She's coming in with chest pain. Probably we should just go ahead and stent that, don't you think? That's what we usually do for severe stenoses. Here's another view of that LAD. Looks pretty healthy, but then all of a sudden really tight. But then down here, looks like a good LAD, apical LAD there, and the LAD bifurcating. So looks pretty healthy, looks really tight for a long segment, pretty healthy. So this is an example of a coronary dissection. She was not treated with a stent, was treated medically, and 3 months later, this is the angiogram. Looks terrific. So unlike plaque rupture, which most of the time should be treated with a stent, and if it can't, bypass surgery, here for spontaneous coronary artery dissection, it's the opposite. Most of the time, this should be treated medically. It can be a big error to put a wire down here and try to stent this, because if you enter the so-called false lumen, you can stent open the false lumen, close off the true lumen, and cause an even bigger infarction. So unless she was having 10 out of 10 chest pain on the cath lab table, refractory to medical therapy, there you would likely try your best to open it up and stent it. Medical therapy is generally the way to go here. As far as the diagnostic algorithm for premature acute MI, here is one. If the patient has obstructive coronary artery disease, as I mentioned, still the most common finding, even in the young. Things that I would consider would be measuring Lp(a). Actually, the European guidelines say to measure Lp(a) in everybody at least once, since it's believed to be largely genetically determined. But at any rate, in a young person having MI, I would check that in addition to LDL, glucose, the usual sorts of things. And then the treatment is pretty much the same as in older people. But for these folks with non-obstructive coronary arteries, the 10 to 20% of young folks with that, want to exclude SCAD, particularly in women. Easy to miss it. It might just be much more subtle than the case I showed you. You want to look carefully for occlusion of small branches. Those are easy to miss. The septal perforator was missed on the angiogram, as I just alluded to. Want to look at an echo for subtle wall motion abnormalities. Always want to test for a tox screen, cocaine, but other things, methamphetamines, so forth. There are a lot of different drugs that can help promote an ACS. And then one can consider things like OCT and look for plaque disruption. And if that's present, well, then you have an etiology. And if it's not, then you might think about things like a workup for a hypercoagulable state, think about coronary embolism, MRI, studies like that, which then can be useful to figure out, was it an ACS, or is it myocarditis, or is it something else? And, spasm's one final thing to consider, and that can be tested for as well with agents given to provoke spasm in the cath lab. Want to be careful about doing that every now and then. That can cause complications. Well, that's all I'm going to say about ACS, broadly speaking. For the remaining amount of time I have, I'm just going to touch upon a few different things in terms of prevention, because I think that's really important for all of you in internal medicine to know, even if you're not so much necessarily dealing with that upfront management of ACS, but the downstream care of patients who've had an ACS. And these are data from the Odyssey outcome trial, looking at ACS patients a month after ACS, and randomization to potent LDL lowering with a PCSK9 inhibitor or placebo. And, there's a large reduction in LDL, about 50–60% reduction, but that's more importantly accompanied by a significant reduction in ischemic events. And that reduction, in fact, includes a reduction in all-cause mortality. Now, that is predominantly in people that have, within the range of people presenting with ACS, higher LDL is greater than 100. But the benefit in MACE is seen even with lower degrees of LDL. And perhaps that reduction in mortality would have been seen even with lower LDL in this trial had the follow-up been longer than the 3 to 4 year average follow-up seen here. So importance of LDL. And I think our thinking in LDL is rapidly shifting in terms of thinking of it more like tobacco and pack years of exposure. Here's a concept of cholesterol years of exposure, meaning that the longer that you had elevated cholesterol, the higher it's been, well, the greater the area under the curve and the greater the cumulative risk for atherosclerotic events. So the lesson here is, in general, for LDL elevation, you want to start early and aggressively for sure in patients that are high risk, such as ones that have presented already with an acute coronary syndrome. And there's some evolving data for very early initiation of PCSK9 inhibitors in MI, starting them on presentation like we do with antithrombotic therapy and statin therapy. Maybe we should do the same with PCSK9 inhibitors. There's a trial ongoing to actually test that concept, the Evolve-MI trial, randomizing about 4,000 patients to a PCSK9 inhibitor or usual care, both STEMI or NSTEMI patients. So hopefully we'll have an answer sometime in the next couple of years about whether we should be treating patients with ACS in a super aggressive fashion with LDL reduction with PCSK9 inhibitors. That's all I'm going to say about LDL. Important to think about blood pressure control in patients with ACS. These are some data, actually Mendelian randomization data, looking at blood pressures and LDL, showing that lower blood pressure, even if the LDL is already low, seems to be associated with lower cardiovascular risk. So it's not just a matter of getting the LDL really low. Sometimes doctors think, oh, if the LDL is super low, 20, 30, well, plaque can't form. People can still have acute coronary syndromes and other cardiovascular events. It really seems like the best approach is to lower the LDL and lower the blood pressure as low as possible, assuming side effects aren't occurring, and that's associated with the best outcomes. Now, these are Mendelian randomization data, meaning these are people whose genotypes have conferred low blood pressure and low LDL. So it's a little bit different than lifestyle intervention or pharmacological approach, but I think probably you can extrapolate in a valid way. That's all I'm going to say about blood pressure. Let me say a little bit about triglycerides. There's been debate through the years. Triglycerides have been in, they've been out. Lots of ways of lowering triglycerides, but I do think the weight of data does support that triglyceride-rich lipoproteins are an independent cardiovascular risk factor. There are a bunch of trials going on to see if aggressive triglyceride reduction with various molecular therapies can reduce cardiovascular events. These agents lower triglycerides by 100% or more. So these will really be the trials that ultimately prove whether triglyceride reduction lowers cardiovascular events. But right now we do have a therapy with respect to omega-3 fatty acids, in particular EPA or eicosapentaenoic acid. There are many omega-3 fatty acids. EPA and DHA are the ones most commonly in supplements, but there are lots of differences between EPA and DHA. EPA stabilizes cell membranes, DHA disrupts them. That's really a topic for another day. But in terms of clinically relevant or actionable data with respect to icosapentaethyl, a purified EPA omega-3 fatty acid, has been shown to lower triglycerides, but more importantly, to lower cardiovascular events, including cardiovascular death and MI and stroke being significantly reduced. And this is in an all-comer sort of cardiovascular population. But if we focus in patients specifically with prior MI or prior ACS, we see very large reductions in ischemic events. And even if we look at the endpoint of cardiovascular death, very large reduction in cardiovascular death in patients with prior MI and elevated triglycerides treated with icosapentaethyl versus placebo. So important to not forget the triglycerides. It's not just LDL in terms of lipids. I don't have enough time to talk about diabetes. That too is a talk on its own, but the SGLT2 inhibitors have been a remarkable advance in the world of diabetes, but also it turns out in the world of heart failure. They're effective heart failure drugs even without diabetes. A number of trials have shown their value in reducing heart failure hospitalizations, in some cases cardiovascular death, in some cases all-cause mortality. But they haven't been studied in ACS. I just bring to your attention two ongoing trials, DAP-MI and IMPACT-MI, that are studying SGLT2 inhibitors in patients presenting with ACS at high risk of heart failure. I'm not involved with it, but DAP-MI will be presented in a few weeks at the American Heart Association as a late-breaking clinical trial. So we'll see if this approach has any merit. IMPACT-MI will be presented next year. A couple of final points I want to make just in terms of changing concepts in the world of ACS, and that has to do with Smurfs. Do you guys know what Smurfs are, by the way, or is that a generational thing? The magical blue creatures? Oh, okay, good. People know what Smurfs are. So in the context of ACS, Smurfs refer to standard modifiable risk factors. So As it turns out, there's some patients that don't have those. Those are patients without SMRF. So standard modifiable risk factors are things like smoking, diabetes, high cholesterol. Some people throw obesity in there. So, those are standard modifiable risk factors. But there are clearly some patients that show up without any. And some of that could just be under recognition, under diagnosis, of course. But some of it seems to be, wow, that person really does seem to have, by current standards, a normal cholesterol, and they deny smoking, and their urine tox didn't show any drugs. I mean, how did that person show up here in the emergency department? Well, there are a number of novel risk factors to consider. And even though cardiologists historically haven't done this, I think they really should get an obstetric history, because it turns out things that happen to a woman during pregnancy can affect her cardiovascular risk at that time and cardiovascular prognosis even decades later. In many respects, you could think of pregnancy as a cardiac stress test. And failing that test is probably like failing a regular stress test, a sign of increased cardiovascular risk. And things like preterm or early term births, hypertensive disorders at the time of pregnancy, small for gestational age infants, and gestational diabetes, even if they resolve afterwards, and many times the OB-GYNs say, oh, well, it was with pregnancy, you're not hypertensive, you don't have diabetes now, don't worry about it. In fact, that has stressed the cardiometabolic system and shown that those cardiovascular risks are lurking. So I want to be really aggressive with lifestyle modification, maybe medical therapy if appropriate in women like that. Another sort of risk factor has to do with race ethnicity. And among South Asians, it's pretty clear that they've got the highest risk of coronary artery disease on the planet. And it's unclear how much of that is due to traditional risk factors that are under-recognized or undertreated, like diabetes or dyslipidemia, or non-traditional risk factors, things like inflammation or genetic inputs. Hard to say, but this is a very high-risk population and does seem to be a risk factor for coronary artery disease and ACS. Another emerging risk factor, hard not to talk about it with the record heat that the planet was experiencing over the summer, is air pollution, which is increasing everywhere. Climate change is contributing to that in a number of ways. The different forest fires that are going on in California and Canada contribute beyond just other inputs. So this can really affect health in multiple ways, but among those ways, it can impact the cardiovascular system and does seem to promote acute coronary syndromes. What to do about it, other than sort of policy type things, is harder to say. Indoor filtration systems do decrease exposure to particulate pollution, so that can be useful. Wearing an N95 respirator can help, but suggesting that could cause a riot. I mean, people are pretty upset, I think, after the pandemic, so that may not gain traction. But potentially there are other approaches, even pharmacological ones, that can decrease inflammation and oxidation that maybe would be useful, would have to be tested, of course. Marijuana use is also a risk factor for cardiovascular disease. That's not a popular statement. Anyone here use marijuana? I didn't really expect anyone to raise their hand, but the fact of the matter is lots of people use marijuana, lots of younger people, lots of older people, children of the 60s, right? I mean, there is a lot of marijuana use, and there's been a lot of legalization in many states, as you're aware. But it is a risk factor for coronary artery disease and ACS. There are lots of potential mechanisms, platelet activation, for example, oxidative stress, direct myocardial effects have been hypothesized, and use is growing. These data are from the 2016-17 era, but you can see in places like California and New York, there's actually a lot of marijuana use, and these data predated a lot of the legalization that occurred. The final risk that I'm going to mention that's ACS related has to do with influenza, because influenza season is starting. So, and you're internal medicine doctors, so you should think about this. And as it turns out, influenza really worsens the prognosis of people that have acute coronary syndrome, such as STEMI. They're more likely to die if they also have influenza. And this is also true with respect to other sorts of outcomes if influenza is present in people with acute coronary syndromes, or in this case, with heart failure. As it turns out, there are data that actually support that influenza vaccination decreases cardiovascular event rates. This is from a meta-analysis from a few years ago where we put together all the randomized trials and showed that influenza vaccination was significantly associated with less major adverse cardiovascular events. And of course, not everyone necessarily believes meta-analyses, but subsequently a dedicated randomized clinical trial out of Sweden proved this point, that influenza vaccination versus control reduced cardiovascular events. And these weren't people that were specifically chosen for influenza prevention. I mean, that's a good enough reason to give influenza vaccination. And here we see as well a reduction in cardiovascular death associated with influenza vaccination versus a placebo. So yet another good reason to go ahead with recommending an influenza vaccination. And an updated meta-analysis including that shows, again, a reduction in cardiovascular events, particularly notable, though, in the ACS patients, less so in the stable coronary artery disease patients. But in the patients with a recent ACS, a very significant reduction in cardiovascular events associated with influenza vaccination versus not. So go ahead and remember to do it, to get it yourselves, et cetera. So, I'm just going to conclude now with a few other points. I covered some ways of reducing residual risk in the ACS patient. I talked a little bit about cholesterol-related risk, triglyceride-related risk. I didn't have time to talk about inflammation-related risk, though there are trials that are starting. Dr. Moran's leading a trial of an IL-6 inhibitor in ACS. Lots of trials still in the anti-thrombotic space. Actually, Dr. Collar was telling me about a trial of something he helped develop looking at pre-hospital treatment in STEMI of giving a potent injectable antiplatelet agent. A couple of big trials in Lp(a) reduction to see if pharmacological approaches, specifically lowering Lp(a), lower cardiovascular risk, and a bunch of diabetes and obesity trials, including data that will come out at the AHA for GLP-1 agonists. That to date, all that data is looking pretty good with respect to reducing cardiovascular events. So I focused on the apex of the risk pyramid, people that came in with ACS, trying to treat them up front, trying to keep them from coming back again with a recurrent or fatal event. But it's important to realize all this is on a bedrock of good primary prevention and risk factor control and primordial prevention, predominantly through encouraging a healthy lifestyle. And it's really internal medicine and internists that are in charge of doing that. Well, thank you very much for your attention. If there are any questions, very happy to take them.
Hi, this is open for questions. My name's Naomi Shah. For those of you who don't know me, I'm the Vice Chair of Medicine for Faculty Affairs. Questions from the audience or on the Zoom? Ben?
Wonderful overview. Great comments. I'm curious about the impact of influenza vaccine. One is that largely through prevention, very illness like acute influenza infection. What are the data related to COVID?
Yeah, great question. So the particular study that I showed, not the meta-analysis, but the single one, wasn't done specifically in influenza season or specifically just to prevent influenza, which is a good enough reason in the right people to give the vaccination. The mechanisms are hard to totally tease out. Some of it might be just reduction of getting influenza and the fact that if someone with heightened cardiovascular risk gets influenza, it's a double whammy. They're more likely to die from it than make it through. The observational data that I quickly showed support that fact that if someone has both an ACS and influenza, they're more likely to die. So part of it could be that. Part of it could also be reduction in inflammation. Inflammation has an important role in generating ACS. Most often, as I said, there's a lipid-rich plaque. Inflammation occurs. That incites plaque rupture, superimposed thrombosis. That's the most typical formula for ACS. And by impeding some degree of inflammation, either just on its own or in association with actually getting influenza, that could have a beneficial effect. As far as COVID goes, there's been, lots of controversy, but I would say the majority of data, of observational data, the randomized data don't clearly show a reduction in MACE, but it was young people that were in a lot of those, or youngish people in a lot of those vaccine trials. So the overall rate of ischemic events was low, but, certainly no evidence that it increases ACS. Young men in particular have a statistically significant real increase in myocarditis, but even that is likely dwarfed by just the risk of badness from getting COVID, even in a young person. But in terms of whether the vaccination per se reduces ACS, there's no data to support that. But there's lots of cardiovascular complications that can occur from COVID. So indirectly, again, preventing COVID remains a good thing to do. I mean, last weekend I got my influenza and COVID booster. I'd encourage people to do the same.
So we have one question from the audience, and then we have a couple on Zoom.
Fabulous presentation and those data, just wonderful, finally. I was
Thank you.
wondering about the role of clonal hematopoiesis and whether or not that now merits consideration in constructing the risk profile.
Yeah, it's a great question. I don't know how familiar you are with clonal hematopoiesis. It sort of bridges the worlds of oncology and cardiology. And, you know, it's something that happens to all of us as we age. And is it just a marker of aging, or is it specifically a marker for cardiovascular disease? Is it on the causal pathway to cardiovascular disease? You know, all that's being teased out. There are a number of studies that are looking at it. In fact, at the Brigham Dana-Farber, there's a CHIP clinic where patients that have this identified can be followed up. Right now, other than intensifying their conventional cardiovascular risk factor modification and following them over time to see what happens to them, there's nothing special that they're getting. But it does, in some studies, appear to be a cardiovascular risk factor or risk amplifier. I'm not entirely sure, though, how much of that relationship is truly independent from age, because even when you adjust for age in analyses, most people just throw age in a model as opposed to entering age in deciles or more sophisticated ways of doing it. So I think it remains to be seen. There is one analysis that I'm part of, but it's been submitted, and it's the folks at TIMI in Boston that put together a bunch of trials looking at CHIP. So hopefully that in a very, very large sample will give another assessment of whether CHIP is truly an independent risk factor or not. You said there were some questions on Zoom?
Yeah. So the first question is more specific, so I'll just move to the second and then come back to that if we have time. So this one is interesting. It's asking what has more effect on risk of cardiovascular disease, inflammation, or LDL? And if I can throw in LPA, that would be great for me personally.
Yeah, no, that's really terrific. You know, as far as the inflammation LDL, the most recent publication's one that my colleague at the Brigham, Paul Ritker, led. I was a co-author along with Steve Nissen from the Cleveland Clinic, and we pulled data from prominent Reduce It in Strength, 3 contemporary triglyceride-lowering trials. But we looked at LDL and inflammation, and the bottom line is both are important. So it's hard to really pick one. But in terms of pharmacological targets, LDL is very well established with statins, high-dose statins, ezetimibe, bempedoic acid more recently, and PCSK9 inhibitors. So the data for LDL reduction is very strong. For inflammation, we don't really know what to do about it. You know, there was a study with canakinumab that did show it reduced cardiovascular events by about 15%, but the company making the drug decided not to pursue a cardiovascular indication because the drug is super expensive and it's got an orphan drug indication, and they're making a lot of money from that, and it wouldn't have made sense to drop the price in using cardiovascular disease. So for business reasons, that's never going to go anywhere. But as I mentioned, there is an ongoing trial, or a few ongoing trials of anti-inflammatories like IL-6 inhibitors. So we'll see if targeting inflammation with pharmacological approaches actually is useful. But my sense is both are really important. But if you get the LDL down really low, there's less substrate for plaque rupture to occur, but it clearly doesn't eliminate plaque rupture. You said there was one very specific question as well?
Yeah, but we're out of time.
Oh, okay.
Just to respect that.
All right, terrific. Thank you very much.